Welcome back to the deep dive. We are going straight into the surgical suite today, but we aren't focusing on the big machines or the flashing lights. We are zeroing in on structures so subtle, so thin, that for centuries they were often ignored or just pushed aside. We're talking about connective tissue fascia and how these seemingly invisible anatomical layers really dictate the success or failure of one of the highest-stakes surgeries in cancer care.
It's so true. When people think about surgery, they imagine removing a large diseased organ. But in rectal cancer surgery, the difference between a clean cure, a devastating local recurrence, or even major life-altering functional loss, it all comes down to navigating tissue layers that can be measured in millimeters.
So our mission today is to really give you the blueprint, the surgical map for navigating this exact, incredibly high-stakes region. We are diving into the anatomical geography immediately behind the rectum, specifically the fascial planes, and how expert surgeons use this map during the gold standard procedure, total mesorectal excision, or TME.
And TME, it just demands this incredible anatomical literacy. It's a pursuit of perfection, really. The fundamental question guiding every single movement of the surgeon's instrument is, am I in the right plane? Because choosing the wrong plane drifting even slightly means immediate danger. You're talking massive bleeding, positive margins that allow the cancer to return, or permanent damage to the nerves that control urinary and sexual function. The entire long-term outcome for the patient hinges on understanding and, well, respecting these fascial layers.
Okay, let's unpack this. Before we can even appreciate the technique, we need the lay of the land. Our sources outline a crucial anatomical triad immediately posterior to the rectum. So we need to understand the three main protective layers separating the rectum from the sacral bone. This is our foundation, moving from the deepest structure of the bone forward toward the organ we intend to remove.
Right. This anatomical triad is the foundation of precision surgery here. When a surgeon performs a posterior dissection of the rectum, they are systematically moving through this sequence. And missing a layer or mistaking one for another has huge consequences.
Let's start at the very back then. Closest to the solid structure of the spine, the sacrum, so A layer 1, the presacral fascia. Our texts call it the danger zone. What is its physical nature? Where is it?
It's the deepest and, I would argue, the toughest layer of the three we're discussing. It lies directly on the anterior concave surface of the sacrum, the bone itself. You can think of it as a dense protective sheet covering the bony pelvis. But its contents, that's what makes it so critical.
And if a surgeon breaches this layer, what are they exposing themselves and the patient to?
They're exposing vital neurological and vascular structures that are embedded or sheltered right beneath this fascia. The first and foremost are the deep sacral vessels, the main trunks of the sacral plexus.
Which is the major nerve network.
Exactly. It forms the sciatic nerve and other major motor nerves and the sympathetic chain running down the spine. This fascia is the covering for all of these essential structures.
But the immediate catastrophic risk is vascular, right? It's all about hemorrhage control, specifically avoiding what's often called Batson's plexus.
Absolutely. The presacral fascia is a critical site for hemorrhage because lying directly beneath it, often woven into its deeper layers and adhering to the bone, is the presacral venous plexus, or Batson's plexus. And this isn't just a handful of typical veins.
Tell us more about that. Why are these veins such a crisis point? I imagine hitting Batson's plexus is not a minor leak. This is the kind of event that turns a planned surgery into an uncontrolled, massive crisis instantly.
You are precisely right, and the mechanism is key. Unlike systemic veins elsewhere in the body, the veins in this presacral space are extremely thin-walled, large in caliber, and most importantly, they are tethered. They are embedded directly in the bone, specifically the basivertebral veins. This anatomical reality means that when they are torn, they can't contract or retract like other veins.
So they can't close up.
They can't. They just bleed copiously into this deep, confined space.
So standard methods like clamping or simply stitching them closed are probably ineffective or at least extremely difficult because of their proximity to the hard bone.
It's exactly right. When this happens, surgeons have to resort to specialized non-standard techniques like applying bone wax or gel foam, or using specific tacks or clips designed to press the bleeding vessel against the bone, just to gain control. The source material is very clear. Avoiding this layer entirely is far, far easier than trying to repair it once breached. The risk is so severe that it dictates the entire surgical mindset in this posterior approach.
Wow. That level of risk must make the approach to the very next layer highly cautious. This presacral plane is essentially a hard stop sign for the surgeon.
It is the ultimate boundary. And recognizing the integrity of this layer influences every single movement the surgeon makes near the sacrum. And this awareness then transitions us neatly to the next layer, the one that guides the surgeon away from that danger zone and closer to the mesorectum itself.
B layer 2, Wall-Dyer's fascia, the anchor. So once the surgeon has meticulously protected the presacral fascia and its dangerous contents, what's the next structural barrier they encounter moving toward the rectum?
That would be Wall-Dyer's fascia. Anatomically, it's a distinct, thin, sometimes almost gossamer-like condensation of connective tissue. It sits snugly between the tough, deep presacral fascia, which is layer 1, and the rectal sheath itself, which is layer 3. It's an intermediate layer.
And what's its composition? Is it fibrous like the presacral layer, or is it something softer?
Well, what's fascinating here is its nature. It is often described as a fibroelastic sheet, but crucially, it is avascular.
Avascular, so no blood vessels.
Right. And that's a key anatomical and surgical detail. It is not designed to carry major nerves or vessels. Its primary function is mechanical. It anchors the middle and lower rectum posteriorly to the sacrum, providing structural support and contributing to the overall stability of the pelvic floor viscera.
So it's an anchor, but maybe more importantly for the surgeon, it signals a distinct surgical landmark, a plane of entry, if you will.
Precisely. Because it is avascular, it provides a clean, white, or shiny visual cue when the surgeon is dissecting sharply along it. It acts as a distinct surgical dissection plane. During rectal mobilization for TME, the surgeon must carefully, often sharply, divide Wall-Dyer's fascia. And this division is necessary to properly free the rectum from its posterior structural attachments to the sacrum and prepare for the deeper oncological dissection.
So Wall-Dyer's fascia serves as a sort of a middle management layer. It's the boundary that, once safely divided, lets the surgeon access the critical outermost envelope of the rectum without endangering the deeper vascular and nervous structures.
That's an excellent analogy. It tells the surgeon, you are now fully mobilized from the pelvic wall, and the next structure you see is the target envelope. Which brings us to the structure that defines the entire oncological outcome.
C layer 3, mesorectal fascia, the fascia propria of the rectum, the envelope. This is the third and final layer of our posterior triad, the structure immediately surrounding the rectum itself.
This is the most critical layer in terms of oncological success. The mesorectal fascia, or fascia propria of the rectum, is simply the outermost circumferential sheath of the rectum.
We often hear the term mesorectum. Can you quickly define that for our listener?
Of course. The mesorectum is the fatty tissue surrounding the rectum. Think of it like a package. And within that package are embedded all the critical structures that rectal cancer uses to spread. The feeding blood vessels, the drainage lymphatics, and most importantly, the lymph nodes. If a tumor has spread locally, those malignant cells are almost certainly contained within this mesorectal package.
So if the mesorectum is the tissue targeted by the cancer, then the mesorectal fascia is the ultimate crucial boundary that the surgeon has to keep intact during removal.
Exactly. This fascial layer forms the actual surgical plane for total mesorectal excision. The goal is not just to remove the tumor, but to remove the entire rectum and all its surrounding mesorectum, the complete anatomical package, and keep it fully encapsulated by this fascial layer. This is why it's often called the envelope or wrapper. If this envelope is breached, the risk of local tumor cell spillage just increases dramatically.
This layer-by-layer map presacral fascia with its catastrophic vessels, Wall-Dyer's as the avascular anchor, and finally the mesorectal fascia as the definitive oncological envelope, it gives us the framework. But now we really need to talk about the stakes, because the entire concept of TME hinges on the integrity of that third layer.
Yes. This is where surgical history and anatomical understanding merge to produce just superior results. The stakes are immense, and they're defined entirely by the state of that fascial envelope we just discussed.
Here's where it gets really interesting, not in a dramatic sense, but in a statistical life-saving one. Why is maintaining the mesorectal fascia intact, meaning achieving a truly pristine specimen, so critical for the patient's long-term survival?
It's all about local recurrence rates, and the data is, well, the data is just overwhelmingly clear. Before the TME technique gained widespread acceptance, when surgeons performed what was often called conventional or piecemeal resection, the local recurrence rate for rectal cancer was shockingly high. We're talking 30 to 40%. The surgeons were simply scraping out the tumor without respecting the fascial envelope.
Wow, that's essentially guaranteeing 1 in 3 patients will have the cancer return locally, a devastating statistic.
It was. However, if the surgeon successfully removes the mesorectal envelope intact, ensuring that the mesorectal fascia remains unperforated and unbreached, our sources show the local recurrence rate drops dramatically. Often into the single digits, 5% to 10%, or even lower in expert hands. That is the statistical payoff of anatomical precision.
So, maintaining an intact envelope is the direct link to achieving a negative margin. Can you clarify what a margin means in this context?
A margin is the ring of healthy tissue surrounding the tumor that is removed during surgery. A negative or clear margin means that the pathologist, when examining the specimen, confirms that no cancer cells were found right at the edge of the removed tissue. If the mesorectal fascia is intact, it acts as a guaranteed clear surgical margin. This is the definition of a good oncological outcome. The tumor, its lymphatics, and the tissue around it are all removed in one clean, contained package.
And conversely, what happens if that envelope is disrupted? If the mesorectal fascia is torn or breached during the dissection, maybe from using a blunt technique or just poor plane identification?
A disrupted mesorectal fascia results in what we call a positive circumferential resection margin, or CRM positive. This means the pathologist found cancer cells right at the edge of the specimen. It suggests that cancer cells might have been left behind, or even worse, spilled into the surgical field during the procedure. Our source material confirms that a positive margin leads to a significantly higher recurrence risk, often shooting right back up toward those historical poor rates. This single factor, the integrity of the fascial plane, is perhaps the dominant predictor of long-term survival in this specific cancer.
It sounds like a surgical catch-22. The surgeon needs to be aggressive enough to ensure all the cancer is gone, but gentle enough to maintain the structural integrity of that surrounding tissue.
It absolutely is. And this surgical failure operating in the wrong plane or being too aggressive, it doesn't just compromise oncological safety. It creates what we call the triple threat for the patient. It threatens all three primary goals of the surgery at the same time.
Okay, let's break down that triple threat. Link the anatomical slip-up to the patient's outcome.
First, as we just established, you compromise oncological safety. A breach risks tumor spillage, or a positive margin, which, again, guarantees a much higher chance of the cancer coming back locally.
Second, the spatial risk.
Hmm.
If you stray too far posteriorly, away from the mesorectal fascia and past wall dyers, you hit the presacral fascia, and that leads directly to hemorrhage control issues. You risk injuring Batson's plexus, so the wrong plane equals massive blood loss.
And third, and this is critically important for the patient's life after cancer, you risk functional preservation. The nerves that control bladder, bowel, and sexual function are housed just outside the mesorectal fascia. When dissection is messy, blunt, or imprecise, these autonomic nerves, the hypogastric nerves, and the pelvic splanchnic nerves are highly vulnerable to damage.
So historically, a procedure that cured the cancer often left the patient with severe life-altering issues like urinary retention, chronic constipation, and inability to have sex, all because the surgeon strayed from the correct fascial layer.
Exactly. The functional outcome is inextricably linked to the precise anatomical plane chosen. Surgeons are trying to find the perfect anatomical corridor, remove all the cancer, stop the bleeding, and leave the nerves untouched. This pursuit of the perfect safe balance, the path that avoids all three threats, is what led surgeons to define a specific idealized path.
That path is known globally, thanks to the pioneering work of one surgeon, Bill Heald, who essentially mapped this ideal corridor. And this brings us to the famous concept of the holy plane.
The term holy plane is truly the defining aha moment of modern rectal cancer surgery. It wasn't a technological advance, it was an anatomical revelation. Before Bill Heald formalized the TME approach in the 1980s, the outcome for rectal cancer was often grim, as we've discussed. Heald recognized that the pelvis wasn't just a jumble of organs. It was organized by continuous, predictable fascial sheets.
So why is it called the holy plane? That's a pretty powerful metaphor. What's the significance behind it?
It's powerful because it signifies the ideal, the gold standard. When Heald and his team demonstrated that meticulous, sharp dissection along this one specific, naturally occurring plane could dramatically drop local recurrence rates and preserve function, it was revolutionary. It's holy because it respects the anatomy so perfectly that it achieves the trifecta of surgical success: oncological completeness, minimal bleeding, and optimal function.
Let's nail down the precise definition of the holy plane. We've discussed the three fascial layers. Where exactly does this plane reside relative to them?
The Holy Plane is defined as the crucial natural antivascular dissection space. Geographically, it is located specifically between the mesorectal fascia, that's layer 3, the envelope we must remove, and the parietal pelvic fascia. The parietal pelvic fascia is the fascia lining the deep walls of the pelvis, which includes the presacral fascia, layer 1.
So the surgeon is essentially following the external surface of the cancer package, peeling it away from the inner surface of the pelvic wall.
That's the simplest way to visualize it. The target dissection happens right outside the mesorectum, but inside the dense parietal wall fascia. And because the plane is naturally occurring in a vascular, the surgeon can use a sharp instrument electrocautery or a scalpel to divide the tissue without encountering major blood vessels or tearing vital structures. This is a deliberate visual dissection, not a blunt, pushing one.
And what's the major benefit of that sharp avascular dissection beyond, the obvious reduction in blood loss?
The key is that sharp dissection allows the surgeon to see the fine structures they are trying to protect, the delicate nerves. Blunt dissection, which involves pushing and tearing tissue, causes edema, bleeding, and nerve traction injury. Sharp dissection maintains visual clarity and minimizes trauma to the adjacent autonomic nerve fibers, preserving their function.
Okay, now let's detail the anatomical boundaries of this holy space. These boundaries tell us precisely what the surgeon is trying to protect and preserve. We need to define the four sides of this corridor.
Starting again with the posterior boundary. The Holy Plane is immediately adjacent to, but anterior to, Waldeyer's fascia, which is layer 2. Waldeyer's acts as the ultimate posterior demarcation line. The correct TME dissection occurs just anterior to Waldeyer's fascia, never behind it.
So if the surgeon feels that tough white Waldeyer's layer, they know they are at the correct depth, safely separating the mesorectum from the deep sacral vessels.
Yeah.
Waldeyer's is the boundary, not the target to be removed.
Precisely. If they breach Waldeyer's, they are immediately in the realm of the presacral fascia and the risk of catastrophic bleeding from Batson's plexus. It's the visual sentinel.
Moving to the anterior boundary, this is where the anatomy gets distinctly gender-specific, marked by another crucial fascial layer, Denonvillier's fascia.
Denonvillier's fascia is a very dense, often white pearly sheet of tissue running along the front of the rectum. It is generally understood to be formed by the fusion of two peritoneal layers that descended into the pelvis during embryological development, creating a strong vertical barrier. It acts as the anterior surgical plane of the Holy Plane.
And its purpose is protection.
Absolute protection and separation. In males, the Holy Plane dissection follows Denonvillier's fascia, which separates the rectum from the vital genitourinary structures, the prostate, the seminal vesicles, and the bladder base. In females, it separates the rectum from the vagina. Staying within the plane anteriorly means respecting this fibroelastic barrier, guaranteeing separation of the tumor mass from these critical anterior organs.
So the surgeon is enclosed posteriorly by Waldeyer's and anteriorly by Denonvillier's, ensuring the full rectum and mesorectum are removed clean, shielded from both the posterior bone and the anterior urinary or sexual organs.
That leaves the lateral boundaries, which are perhaps the most vital for long-term patient function. Laterally, the Holy Plane is defined by the need to protect the entire autonomic system that controls pelvic visceral function, specifically the hypogastric nerves and the pelvic splenic nerves.
Let's delve deeper into this lateral area. Why are these nerves so easily damaged if the surgeon strays laterally? Where are they relative to the mesorectal fascia?
These nerves, which eventually combine to form the inferior hypogastric plexus, which is the main switchboard for pelvic function, are situated just outside the mesorectal fascia. They are running adjacent to the target, the mesorectum, but they're not contained within the mesorectal envelope. They are parietal structures.
So if a tumor is large and has invaded laterally, the surgeon faces an immense dilemma: preserve function and risk leaving cancer, or remove the cancer aggressively and destroy the nerves.
That is the ultimate tension. But the principle of TME in the Holy Plane dictates that by staying strictly within the fascial plane, right up against the mesorectal fascia but not breaching it, the surgeon naturally mobilizes the tumor package away from the nerves. The key insight of HEALED was that cancer very rarely breaches the mesorectal fascia laterally until late stages. Therefore, if you follow the fascia, you achieve a negative margin and you preserve the nerves.
That is a profound insight. The anatomy naturally organizes the pathology away from the function.
It does. By defining the precise fascial corridor, the technique ensures separation of the diseased, tumor-bearing tissue from the critical nerve pathways.
This brings us back to the ultimate so what for the patient, the profound significance of this meticulous technique. Let's synthesize the main benefits of sticking to the holy plane.
The crux of significance is really fourfold. First, the oncological benefit. Complete tumor resection with an intact mesorectal envelope, ensuring a negative margin and dramatically lowering local recurrence rates.
Second, the functional benefit. By maintaining that precise, sharp, avascular dissection plane, you prevent injury to the autonomic nerves, the hypogastric and pelvic splanchnic nerves, thereby preventing the life-altering postoperative urinary, bowel, and sexual dysfunction that plagued older surgical approaches. The quality of life post-surgery is fundamentally protected by this anatomical respect.
Third, the hemostasis benefit. The natural vascularity of the holy plane minimizes intraoperative blood loss. This reduces the need for transfusions, shortens operating time, and makes the procedure safer, especially for frail patients.
And finally, integrating all three, the surgical reproducibility. Because the plane is anatomically defined and predictable, the results are consistent. This ability to replicate excellent oncological and functional outcomes across various centers around the world is what confirmed TME as the gold standard.
The holy plane is not just a concept defined in a textbook. It is a surgical philosophy that proves that perfect results are often achieved not by complex new technology, but by a deep and abiding respect for anatomical reality.
It's incredible how such a complex outcome is simplified by adherence to an invisible boundary. But we have been focusing heavily on the deep pelvic floor. To complete the picture, we need to understand how these fasciae connect to the rest of the abdomen, particularly when surgeons start the procedure from above, high up near the major vessels.
Yes, and this high approach is crucial. When TME is performed, especially minimally invasively, the initial dissection often starts high up, near the sacral promontory, where the abdomen essentially transitions into the deep pelvis. If the surgeon messes up here, the nerves are damaged before the deep dissection even begins.
So, A, continuation, infusion. What happens to the various layers of pelvic fascia at this high structural point, where the large bowel vessels begin to descend?
At the sacral promontory, the entire fascial system transitions. The visceral pelvic fascia, the general wrapping around the pelvic organs, has to become continuous with the endo-abdominal fascia, which is the lining of the abdominal cavity wall.
So the wrap around the organs meets the lining of the container they sit in? How does this fusion manifest surgically?
They merge and condense, establishing a distinct and critical separation. This fusion helps establish a clear boundary between the retroperitoneum, the space behind the abdominal lining where major vessels run, and the deep pelvic cavity. The surgeon performing a high ligation of the superior rectal artery must understand this fascial continuity to ensure they remain in the correct avascular plane laterally, safely away from the large nerves descending into the pelvis.
And B, reinforcement and support. Does this physical fusion make the posterior structures like the presacral fascia thicker or more complex at this level?
Yes. The visceral fascia contributes structural fibers, causing the presacral fascia, that's layer 1, the one lying in front of the sacrum, to noticeably thicken at the promontory level. It becomes a major fascial sling.
Which means the danger zone of catastrophic bleeding from Batson's plexus continues to be a factor even at the very top of the dissection.
Exactly. Our source material emphasizes that this reinforced area still houses the critical presacral venous plexus. So, the hemorrhage risk, that need for meticulous, sharp dissection right on the bone, is absolutely present even in the high approach near the promontory. The surgeon must always assume they are operating near the Batson's plexus until the rectum is fully mobilized.
C, the hypogastric sheath, pathway for nerves and vessels. This fusion point is also responsible for creating one of the most critical conduits of the pelvis, the hypogastric sheath. This structure sounds like the major utility hub for the pelvis.
It is the main highway. The hypogastric sheath, sometimes referred to as the lateral ligament of the rectum, arises directly from this transition and condensation of the visceral pelvic fascia at the promontory level. It's not just a flat sheath. It's a three-dimensional fibrofatty cylinder that extends from the sacral promontory all the way down to the pelvic floor.
And what essential structures are traveling inside this conduit?
It carries the structures necessary for the rectum and pelvic floor. Specifically, the major blood supply, the superior rectal vessels, and the middle rectal vessels are encased within its medial wall. But most importantly, it acts as the protective tunnel for the crucial nerves we want to save. The entire autonomic nervous system descending from the abdomen, including the hypogastric nerves.
So if a surgeon is starting their TME high up at the promontory, they need to identify the sheath immediately and dissect medial to it to protect those nerve bundles before they even begin the deep dissection.
Absolutely. The identification and lateralization pushing it safely aside of the hypogastric sheath is the first and most vital step of nerve preservation in the high TME approach. If the surgeon cuts or damages the sheath at the promontory, they sever the connection, and the nerves downstream in the deep pelvis will be functionally disabled.
So this means the difference between a patient having normal urinary and sexual function versus major impairment often comes down to the first 30 minutes of the surgery and whether the surgeon correctly identified the fascial bundle containing those hypogastric nerves.
That is the clinical relevance of the promontory transition. Understanding this anatomical shift is vital. It allows the surgeon to properly identify the autonomic nerves early. It's an example of how anatomical knowledge allows for preemptive nerve sparing. By identifying the hypogastric sheath and preserving it high up, they safeguard the entire pelvic nervous system before beginning the challenging, deep, confined dissection.
And we have to reinforce that the hemorrhage risk associated with Batson's plexus embedded in the reinforced presacral fascia continues throughout this space. So the anatomical understanding of this transition prevents both early functional damage and early massive bleeding.
It connects everything. The high dissection establishes the lateral boundaries of the holy plane by identifying the hypogastric sheath, and the deep dissection follows the posterior boundaries of Waldeier's and anterior boundaries of Denon-Villiers, all to remove the mesorectal fascia intact. It is a single, continuous precision effort guided entirely by layers of fascia.
This entire journey, from the deep sacrum to the rectal wall, defined by three layers: presacral, Waldeier's, mesorectal, and perfected by the surgical adherence to the holy plane, it really reveals that the most complex surgical results are achieved through the simplest means: respecting boundaries. So, to synthesize this deep dive for you, the learner, we've mapped the crucial posterior anatomical triad. We learned that the integrity of the outermost sheath, the mesorectal fascia, dictates the oncological outcome, the statistical difference between local cancer control and devastating recurrence.
And we formalize the holy plane, the gold standard of surgical dissection described by Heald, which is the naturally avascular space nestled between the mesorectal fascia and the deeper parietal pelvic fascia. Its boundaries are defined not just by structural support like Waldeier's fascia, but fundamentally by what the surgeon must absolutely preserve: the hypogastric sheath high up and the autonomic hypogastric and pelvic splanchnic nerves running laterally.
This conversation underscores the central lesson for anyone interested in advanced medicine. Knowledge of microanatomy is power. The goal is not just to aggressively cut out the tumor, but to meticulously follow these natural defined fascial planes to guarantee a clean oncological resection while simultaneously ensuring the patient retains essential, life-defining autonomic functions.
The success of total mesorectal excision is a perfect illustration that sometimes the most significant advances in surgical oncology are not born from billion-dollar robots or novel pharmacology, but on a deeper, more profound and respectful understanding of anatomy that has been there for centuries. It's about leveraging existing anatomical realities for superior patient outcomes, moving from blunt force to surgical finesse.
It makes you step back and truly appreciate the human body as a structure defined by sophisticated layers. If the holy plane exists in the pelvis, requiring strict surgical adherence to natural avascular fascia for optimal cancer and functional results, are there similar yet still undefined fascial planes waiting to be discovered that could simplify complex resections in the thorax, the neck, or other areas of high nerve density?
Indeed. The pursuit of the holy plane wasn't about creation. It was about observation. It raises the provocative question: are we already operating near or around other crucial, yet only partially identified, avascular fascial planes that could transform another major surgical field? If only we dedicated the anatomical rigor to defining their boundaries.
Something for you to mull over as you process this deep dive into the world of surgical precision and anatomical respect. Thank you for joining us on the deep dive.